presentation is titled Trio US B12 Talent Neoadjuvant Trastuzumab Deruxtecan with or without anastrozole for HER2-low, HR-positive early-stage breast cancer will be presented by Dr. Aditya Bardia from the Massachusetts General Hospital. Aditya.
Thank you, Dr. Arteaga. I'd like to thank the organizers for selecting this study for the press conference. On behalf of my co-investigators, it's my pleasure to present the results of TRIO US B12 Talent, an investigator-initiated clinical trial looking at neoadjuvant trastuzumab deruxtecan with without anastrozole for hormone receptor-positive HER2-low early-stage breast cancer. As a brief background, T-DXd has demonstrated impressive efficacy in metastatic HER2-low breast cancer. However, the efficacy in localized HER2-low breast cancer is not known. While neoadjuvant anthracycline taxane-based combination chemotherapy is often utilized to treat high-risk localized hormone receptor-positive breast cancer, it can be associated with low pathological complete response rates, about 5%, including HER2-low, radiological response rate of about 50%, and significant toxicity, including myelosuppression, peripheral neuropathy, cardiomyopathy, and risk of leukemia. So we designed an investigator-initiated clinical trial to evaluate the efficacy of T-DXd for patients with localized hormone receptor-positive HER2-low breast cancer. And given the crosstalk between ER and HER2, we also evaluated whether the addition of endocrine therapy will improve efficacy of T-DXd in this setting. So this is the study design of the TALENT trial. Patients with hormone receptor-positive HER2-low breast cancer who had stage 2 to stage 3 disease were included. They were randomized 1-to-1 to either T-DXd alone or T-DXd plus anastrozole. Initially, patients received 6 cycles, but then after approximately half of the patients had been enrolled, an amendment was made to increase the number of treatment cycles from 6 to 8. Then after that, patients underwent surgery, and after surgery could receive additional adjuvant therapy as per discretion of treating investigator. Baseline tissue biopsy was collected before start of T-DXd, during treatment with T-DXd, and at the time of surgery. From September 2022 to October of 2020 to October of 2022, 58 patients were included in the clinical trial. 29 were randomized to Arm A, which is T-DXd alone, and 29 were randomized to Arm B, which is T-DXd plus anastrozole. Majority of the patients were able to complete the treatment. Only a minority discontinued because of side effects. There was 1 patient who had disease progression. In terms of baseline characteristics, the baseline characteristics were well balanced between the 2 arms. Majority of patients had HER2-low defined as IHC 1+. About 80% of patients in this clinical trial had HER2 IHC 1+. About 50% of patients, so that's about half of the patients, had lymph node positive disease. So we looked at the objective response rate with T-DXd based on imaging. So patients had baseline imaging, and then after treatment with T-DXd had repeat imaging. It was the same modality. Overall, in patients who received T-DXd as a single agent, the response rate was 68% with 2 complete responses. In patients who received trastuzumab deruxtecan plus anastrozole, the response rate was 58%, and there were 2 complete responses. We then looked at the change in HER2 IHC from baseline to surgery, so looking at the baseline biopsy specimen and then looking at the surgical specimen after treatment with T-DXd. We looked at the HER2 IHC expression, and this was central review. As you can see from this figure, there was a change in HER2 IHC expression in about half of the patients after treatment with T-DXd, And for majority, 88.2% of patients, there was decrease in HER2 expression with TDXD treatment, including a subset of patients having HER2 IHC 0. Now, I would caution that the observed change in IHC immunostaining does not necessarily reflect the change in HER2 protein expression in the carcinoma cells. And then finally, in terms of residual cancer burden, or RCB, RCB 0 refers to PCR, or pathological complete response. RCB 1 is near PCR. In arm A, which is TDXD alone, there was one patient who had RCB 0, and there were two patients who had RCB 1. In arm B, there were three patients who had near PCR or RCB 1. The data for patients who received 6 cycles is pretty much complete, but for patients who received 8 cycles, surgical outcomes are pending for 24% of patients treated with TDXD alone and 31% of patients treated with TDXD plus anastrozole. So we'll present updated results when we have the outcomes for these patients as well. In terms of adverse effects related to TDXD, the number one side effect seen with TDXD was nausea in both the arms. In terms of dose reductions, the percentage of dose reductions was low. 5.2%, or 3 patients needed a dose reduction because of AEs. There were no cases of grade 3 or 4 pneumonitis, and there were no cases of cardiomyopathy. There was one death due to myocardial infarction after severe GI toxicity, possibly related to TDXD. So in conclusions, neoadjuvant trastuzumab deruxtecan demonstrated preliminary evidence of clinical activity in HER2-low, hormone receptor-positive localized breast cancer. The toxicity profile was consistent with previous reports. We saw dynamic changes in HER2 expression after treatment with TDXD. The addition of endocrine therapy did not appear to enhance efficacy, but I would exert caution given the small numbers. The study is a translational study. It's a rich platform for additional research to evaluate other methods of HER2 detection, to develop predictive biomarkers, and to understand mechanisms of resistance in the residual tumor that could guide future therapeutic strategies, including combination therapy. Overall, this is the first report of neoadjuvant TDXD for patients with hormone receptor-positive HER2-low breast cancer, and provides the groundwork for future studies with antibody-drug conjugates for patients with early-stage breast cancer. Thank you.
Thank you, Aditya. Can you comment on the tumor grade of the patients enrolled in this study, and whether you're concerned that maybe some low-grade tumors, too many low-grade tumors could have been enrolled in this study, perhaps explaining the lower, RCB and path complete response rate?
Yeah, no, good question. So this relates to grade. We know that tumors that are grade 1, the response rate to neoadjuvant chemotherapy is very low, and tumors that are grade 3, it's a bit higher. In this clinical trial, about 1/3 of patients who were enrolled had grade 3 tumors. Okay. So there was comparatively higher proportion of patients who had grade 3 tumors, and I think it reflects investigator selection. Patients who had grade 3 tumors, the investigators were more inclined to consider this study. And we'll present these results for the press release. We didn't have time for all the slides, but we'll present these results today.
Thank you.
Hi, Neil Osterweil with MD Edge Hematology Oncology. Dr. Bhartia, could you please explain a little bit more about the crosstalk between ER and HER2? What exactly you mean by that? And also, have you considered using other endocrine agents or selective disruptors, for instance?
Yeah. Dr. Arteaga can probably speak to the ER-HER2 crosstalk as well. His lab has done extensive work. But essentially, in tumors that become endocrine resistant, you see an increase in the HER2 pathway. And if you block ER, you see that HER2 goes up, and vice versa. If you just block HER2 alone, the expression of ER can go up. If you block, similarly, PI3 kinase alone, the expression of ER goes up. So there's this crosstalk that's considered between ER and HER2. So that's why in the past there was interest in dual blockade, where you block both ER and you block HER2. I think that's relevant with antibody-based therapies or tyrosine kinase inhibitors. But with an ADC, that might not be much relevant, because if you have an ADC, you need HER2, the ADC binds to HER2, then gives the payload to the cancer cells and essentially kills the cancer cell. So I'm not sure how much the crosstalk is really relevant when you're talking about ADCs, particularly ADCs like T-DXd, which also have a bystander effect.
Okay. But in the case of, since you didn't see any effect, would you still consider, I know you cautioned against, because of low numbers, but would you still consider using endocrine therapy going forward?
I think we need additional data. Yeah. So far, we've not seen any data to suggest that with T-DXd, the addition of endocrine therapy is beneficial. In DESTINY-Breast04, which was the pivotal trial looking at T-DXd in metastatic hormone receptor positive HER2 low breast cancer, patients received T-DXd alone, not with endocrine therapy. So probably we need to start in the metastatic setting, seeing whether the addition of endocrine therapy, including newer endocrine agent, adds to the efficacy of T-DXd.
Okay, great, thank you.
We have a whole symposium of the crosstalk between ER and HER2 at 11 o'clock today. Hall 3.
Hi, Rebecca Glass, M3. You mentioned that there was a change in expression of HER2, but that doesn't necessarily mean a change in protein in the carcinoma cells. Is this because we're not seeing transcription into the protein?
Yeah, the point was you're just looking at IHC staining. It's not single-cell sequencing. So unless you have single-cell sequencing, you cannot say that there was a change at a cellular level. You're just talking about the change in the tumor bed. And the other thing is the baseline biopsy was a core biopsy, while the surgical specimen is the full specimen. So we cannot talk about individual cellular change, but on an average, if you will, there was decrease in HER2 expression.
Thank you.
Let me ask you something. Can you comment on the discordance rate that you show in one of the slides? Is that concerning to you? Between central read and, again,
local read.
Local read, yeah.
To your point, there's a whole session today that'll talk about HER2 low, and David Rim would present data on staining related to HER2 low. This whole classification of IHC 1+ and even 0 or 2+ versus 1+ is a bit artificial because it's dependent on the percentage of staining. So if more than 10% of cells have complete staining, that's IHC 2+, but if it's incomplete staining, it's 1+, and if less than 10% of cells have incomplete staining, it's 0. And differences in the type of antibody that's used, the fixation conditions related to the antibody, all of that can have an impact. So there could be some variability between the labs in terms of the HER2 results. So for HER2 positive in general, but particularly for HER2 low, I think we need better analytical assays and more standardization of the HER2 IHC technique. As a reminder, this HER2 classification was developed for trastuzumab, and the goal was to identify high HER2 expressors. It was never developed to identify low HER2 expressors. And now that we have these ADCs, I think we need to revisit and develop better analytical tools to identify low HER2 expressors.
Sounds like something that where artificial intelligence can help us.
Absolutely, absolutely.
All right, any more questions?
We have a couple of questions from the webcast. Leah Lawrence with OBR Oncology asks, what time of benefit might patients see with possible omission of endocrine therapy in this setting? I think that may have been what type of benefit, sorry.
Or what size of benefit, so yeah.
Yeah, so endocrine therapy is always the mainstay of management of ER-positive breast cancer. And in patients who receive neoadjuvant chemotherapy, or even in this trial, patients who receive neoadjuvant T-DXd alone, after surgery, they would get endocrine therapy in the adjuvant setting, and that would either be endocrine therapy alone, or if a patient has high risk, they'll get endocrine therapy plus abemaciclib. So endocrine therapy would remain. I think the question in ER-positive breast cancer is who needs chemotherapy in addition to endocrine therapy, and similarly, who needs T-DXd or these newer ADCs in addition to endocrine therapy.
Is there a second question from the webcast?
Yes, there's one more. This is from Fran Kritz with Everyday Health, and she was hoping you could clarify, was the reason for initiating the trial because the standard therapy has high rates of toxicity, and was the goal for treatment less toxicity or both less toxicity and also greater efficacy?
Yeah, I would say both. We need better options for patients with hormone receptor positive breast cancer, and the current standard of care is neoadjuvant anthracycline taxane-based chemotherapy. If you look at the PCR rate or even radiological response rate, it's not very high. So we need more efficacious agent, but we also need agents that have lower toxicity given the cardiomyopathy, neuropathy, alopecia, and other side effects that are seen with chemotherapy. So the goal is always twofold. Can we improve on the efficacy, and can we lower the toxicity?
And since we're on that point, what about in this patient population, endocrine therapy and CDK4/6 inhibitors? Isn't that an option for them?
Yeah, absolutely. For a subset of patients, neoadjuvant endocrine-based therapy might be the best. So for tumors, say, that are grade 1 or maybe for lobular carcinomas, endocrine therapy alone could be sufficient, even in the neoadjuvant setting. There's also interest in looking at assays like Oncotype DX. We use them in the adjuvant setting, but can you use in the neoadjuvant setting to select who should get endocrine therapy versus chemotherapy? And there's some data to suggest that you can use Oncotype DX in this setting. Whether the addition of CDK4/6 inhibitor adds to endocrine therapy, I think that's subject to ongoing investigation. There are some trials which have shown that the PCR rate maybe increases a bit, but definitely Ki-67 decrease is higher with the addition of CDK4/6 inhibitor.
Thank you. All right. I think no more questions in the webcast, Julia?